as well as on obesity.
All right, awesome. Okay, we're good to go then. So, my name's Dr. Raymond Kodsi. I'm a consultant endocrinologist. I work at Fairfield and Campbelltown hospitals. I also work privately in Smithfield and at Campbelltown Private Hospital as a consultant endocrinologist. So I've been asked to talk today about obesity drugs and specifically the newer treatments related to obesity, because there's a lot on the horizon coming through now and in the future. I have no conflicts of interest. I have no declarations to make tonight. And today, I'll start by talking about obesity prevalence, but Ken's already touched on that a little bit. I'll talk about obesity as a disease. I'll also talk about some of the older medications that we have for obesity, as well as things that have come out recently or that are about to come out, and what's on the horizon in the future. So when we talk about obesity, I mean, we all know this, but generally on a population level, it's useful to define obesity by BMI. And that's what all the studies and all the trials use to define obesity. It's practical on a population level, but probably not the best way to measure obesity on an individual basis. BMI, although it contains a lot of data on weight versus height, it doesn't actually tell you much about how obesity impacts on a patient themselves. So, for example, you could have a patient with a BMI of, say, 42, age 20 years old, no comorbidities whatsoever, and they are totally healthy, but definitely in the obese category for BMI. You could also get someone who's got a BMI of, say, 31, who's 70 years old, has hypertension, has type 2 diabetes on insulin, has high cholesterol, has osteoarthritis in both their knees, can barely get out of the house. And so obviously the obesity for one of these people impacts on them a lot more than the other person. So the BMI alone should not be the determining factor in determining whether someone gets obesity treatment or how aggressively you manage obesity. So there are other factors such as age, family history, comorbidity burden, and patient motivation, which all determine the kind of approach that we should take with people who have problems with excess adiposity. And to look at the prevalence of excess weight, so this is 2017 to 2018 data from the Australian Institute of Health and Welfare. 67% of adults in Australia are living with either overweight or obesity, and 31% of people are living with obesity, and the remainder, so 35 to 36%, are living with overweight. So 10 to 20% weight loss would move everybody down one category in terms of BMI. So people who are in the overweight range with a BMI of 25 to 30, losing 10 to 20% of their weight would move them into the normal or healthy weight range. People who are obese class 1 would move into the overweight range. Obese class 2 would move into class 1. So that 10 to 20% number is kind of a magic number. And I'll come back to why 10 to 20% is an important number later on in the talk. But yeah, suffice it to say that, if we were able to lose 10 or 20%, then that would make a huge difference in sort of the prevalence of obesity and overweight. So this is a color map, again, from the Australian Institute of Health and Welfare on prevalence of obesity in all of the PHNs in Australia. As you can see, obesity is disproportionately affecting people living in remote and regional New South Wales and regional Australia. But the urban areas in general tend to have lighter colors and have lower rates of excess weight. I've also highlighted Sydney specifically here on this diagram. So these are the PHNs in Sydney. And it might be a little bit small to read from the back, but Southwest Sydney is sort of up here. So of all the PHNs in Sydney, I've highlighted all the PHNs in the Sydney area. Southwest Sydney ranks the highest in terms of the prevalence of overweight and obesity among the PHNs in Sydney. And in fact, it's the only PHN in Sydney that ranks higher than the national average rate of obesity in Australia. So this is kind of the perfect place to address the obesity epidemic that's affecting us, because it's worse here than in other parts of Sydney. And before I get into treatment, I did want to clarify some things about obesity management and what causes obesity, because there is still a widespread belief among the general population and even among health professionals that obesity reflects a personal failing of some kind, and it reflects a lack of self-discipline. And there exists this stigma around excess weight and a belief that people with excess weight have somehow brought it upon themselves or choose to remain at their current weight. But our current understanding of weight has changed a lot in the last 20 to 30 years. And we now know that genetics are one of the most important determinants of weight. So this reference here is Stunkard et al. This person conducted a study in the 1980s where they looked at people who were adopted and compared the weight of the adoptees to their adoptive parents versus the weight of their biological parents. And they found that there was a strong correlation between the weight of the adoptees and their biological parents, who they have not lived with. But there was little to no correlation between the weight of the adoptees and their adoptive parents, which is quite surprising. You'd think living in the same household, they would have similar weights, but there's almost no correlation. And this is one piece of evidence that linked genetics and the importance of genetics to weight. Also, there are many factors that can influence body weight apart from genetics, but cannot cause one to become obese on their own. So I'll get through that in the next slide, but the brain maintains weight around a set point, which is determined genetically, which is the important thing to say. So obesity, although lifestyle factors and external factors can affect a person's weight, the genetics are very key in determining an adult's final weight. And so this diagram here shows how weight is determined in humans. So there are external factors from the environment, so things like taste and smell of food, palatability, availability of food, and social habits that impact on the regulation of weight by the body, which is highlighted in the square. There are also individual factors on the right, such as genetics, that wire a person to a certain weight. And all of these things come together to influence the homeostatic systems that are in place to determine weight and energy balance. So this is a very complex system. I'm not going to get into excessive detail tonight, but the set point is controlled by the brain, and it's a complex system that involves the gut, the liver, the pancreas, muscle, and adipose tissue as well. This is controlled by hormones including glucagon-like peptide 1 or GLP-1, glucose-dependent insulinotropic polypeptide or GIP, leptin, neuropeptide Y, ghrelin, insulin, amylin, and glucagon. And all of these hormones work together to maintain a defended fat mass. With weight loss, the levels of all these hormones change. And they change in such a way that it drives the fat mass back to a determined set point, which again is determined genetically. Obesity is a result of an inappropriately high set point of this defended fat mass. And treatment requires resetting of the defended fat mass to a lower point to maintain a weight that is in the normal range. So understanding this biology of how obesity occurs and how weight is determined is important in managing obesity. So now that we've established that the body has a defended fat mass, which is determined genetically, and we add the fact that weight loss results in long-term hormonal and metabolic changes that encourage return to this weight set point, we would have to conclude that if we were to use medication for weight loss, we would have to use it long-term or lifelong to maintain that weight loss. So it's something that I didn't really grasp until the last couple of years of my advanced training. But when you think about obesity as a chronic disease, and we look at other chronic diseases like hypertension and diabetes, for example. So if a patient came to you with a blood pressure of 160 on 90, and you started them on an antihypertensive medication, and they come back to you in a couple of months, their blood pressure is 120 on 80, would we say, well, you're cured of your hypertension. You don't have hypertension anymore. We can stop your Carvia or your thiazide diuretic or whatever medication you've started on them because your hypertension is cured. You don't have hypertension anymore. We wouldn't do that because we know what would happen. We would know that the patient's blood pressure would go back to what it was before. Similarly with diabetes, someone comes in with a HbA1c of 11%. We start them on metformin plus other agents to bring the HbA1c down to target. When they come back to your clinic and the HbA1c is 6.7%, do we say, well, you don't need your metformin and your GLP-1 and your insulin medication anymore because your diabetes is cured? We don't say that. So it might be because the drugs that we've used in the past for obesity have had such side effects that have been not very desirable at all, that we say that, well, we'll use it for short term, and once your weight is down to a certain level, then we don't need to use it anymore. But our thinking of obesity really needs to change in order to actually successfully treat patients, because obesity should be treated as a chronic disease because it is a chronic disease, and medication should be used lifelong, or whatever intervention is used to bring obesity under control should be used lifelong to keep obesity under control. So I have here a list of medications that we use for obesity now. So on the left are sort of the older medications that we know about, and on the right are some of the newer medications that are coming to market. So semaglutide we currently have available in Australia as Ozempic, but Wegovy is the high-dose semaglutide which is actually being studied and used for obesity management in the trials. I've been told by our reps from Novo Nordisk that it's TGA approved here in Australia, but supply should be coming in next year. So it's something to watch out for. I'll start off with talking about the older medications that we have. The oldest of them is phentermine or Duramine. So phentermine is a sympathomimetic agent, and through its activity, it causes appetite suppression. It's been used for decades, but it has a lot of side effects, including hypertension, tachycardia, dry mouth, insomnia, agitation, constipation. Patients who I've talked to who have been on phentermine, insomnia seems to be a very limiting factor. People feel like they can't get to sleep. They feel like it affects their mood quite severely. And there's a lot of contraindications as a result of its method of action, including, if a patient has uncontrolled hypertension or heart disease, arrhythmias or psychiatric disorders, substance abuse, hypothyroidism, then it's contraindicated and it can't be used. And a lot of obese patients or people with excess weight issues tend to have hypertension. So that already kind of red cards them from using this medication. It is available in several preparations, so 15, 30, and 40 milligram preparations. Usually we'd start at a low dose and up titrate to reduce the risk of some of these side effects. And the average weight loss that can be expected on phentermine is somewhere between 5 to 7.8%. So let's say 5 to 8%. At a cost of around $135 a month on the maximum dose. For some people, that's affordable, but for some people that the price in terms of side effects and in terms of money cost is a little bit too high. It can, however, be combined with topiramate. Topiramate is an anti-epileptic medication which has the side effect of weight loss. It's not sold, phentermine and topiramate together are not sold as a single product in Australia at the moment. And topiramate technically should be prescribed off-label, so that's fine. We can prescribe things off-label as long as patients are consented, they understand the risks, they understand that it's not technically TGA approved for the indication of weight loss, only to treat seizures, but it does have the side effect of weight loss and it has been shown to be very effective in doing so. I do have some patients who get it from a compounding pharmacy where the pharmacy compounds the phentermine and topiramate together into a single pill. So that is a possibility as well, rather than prescribing the two tablets separately, although I'm unsure of the costs. Generally, if a patient is started on topiramate, we usually start at a low dose of 12.5 milligrams, which is half of a 25 milligram tablet. That's the smallest tablet is 25 milligrams that we have available in Australia. And we would titrate up to a maximum dose of 100 milligrams a day. The average weight loss over placebo is 6.5 to 8.5%, so it maybe adds an extra sort of 0.5%. percentage weight loss to phentermine alone. The adverse effects of topiramate include paresthesia, confusion, renal stones. In high doses, some patients can get glaucoma. And of course, well, like all the other obesity medications that I will talk about tonight, it is contraindicated in pregnancy. Specifically with topiramate, it can cause cleft lip in unborn children, so contraindicated in pregnancy. Xenical or orlistat, that's also another drug that's been around for a couple of decades now. It works by inhibiting pancreatic and gastric lipases, and it decreases the absorption of dietary fat. The dose is 1 tablet of 120 milligrams with each meal, a maximum of 3 times per day, so breakfast, lunch, and dinner. The average weight loss, though, is pretty minimal, at 3% after 1 year of treatment. So, imagine somebody who comes to you with a weight of 100 kilos, after 1 year of going through steatorrhea, oily spotting, flatulence with discharge, fecal incontinence, they've lost from 100 kilos down to 97 kilos, which is within the margin of error in terms of, weight scales and things. They're probably not going to be super happy on this medication, especially if they've been paying $110 a month for it. So it's not a medication that's kind of really used very much at the moment because of its undesirable side effects and and because of the minimal sort of results that you get from it. Contrave is a newer medication. It's been around for a couple of years now, at least for 5-ish years or so, 5 to 6 years. It's sold as a single tablet containing 8 milligrams of bupropion and 90 milligrams of naltrexone. So bupropion is a norepinephrine dopamine reuptake inhibitor, and naltrexone, as we might know, is an opioid antagonist. The dose starts generally with 1 tablet a day, uptitrated weekly by 1 tablet to a maximum dose of 2 tablets twice a day. So week 1, take 1 tablet in the morning. Week 2, 1 in the morning, 1 in the evening. Week 3, 2 in the morning, 1 in the evening. Week 4, 2 tablets twice a day. And then you continue on that. The average weight loss over placebo is about 5 to 6%. And it does cost about, in $2,023, it costs around $250 for 112 tablets, which will give you 28 days of treatment on the maximum dose. It can cause nausea, vomiting, headache, dizziness, dry mouth, seizure. Obviously, if people get seizures, it's contraindicated, as well as in people with uncontrolled hypertension, bulimia, or anorexia nervosa. So now to sort of the major newer treatments that are coming on for obesity management, GLP-1 agonists. So these are the hot new kid on the block. GLP-1 helps regulate appetite and lowers blood glucose. It also acts on the hypothalamus to increase satiety, and it acts on the gut to slow gastrointestinal motility and increase satiety, and it acts on the pancreas to upregulate insulin secretion. So it works in a number of ways, not only to control obesity, but it also helps with insulin release. Therefore, it helps with type 2 diabetes, primarily why these drugs were studied as a method to help control type 2 diabetes. Byetta is a GLP agonist that used to be on market here in Australia. It's no longer sold in Australia. Bydureon is also no longer sold in Australia. So liraglutide is the medication, is the oldest of the GLP-1s that we have in Australia now. It's sold as Saxenda for the control of obesity. And at the moment, it's the only TGA-approved GLP-1 agonist for obesity at the moment. Other GLP-1 agonists are not approved for the management of obesity, only for the management of type 2 diabetes. Doesn't mean you can't use them for obesity management, but the TGA has approved Saxenda for obesity management. Saxenda is given as a once daily subcutaneous injection, which is self-administered. You can see the pen here. It looks very familiar to anyone who's ever seen an insulin pen or some of the other GLP-1 devices that are out there. And it's quite easy and simple to use. The dose starts at 0.6 milligrams daily. Every week, the dose is increased by 0.6 milligrams up until a maximum dose of 3 milligrams, or the maximum tolerated dose by the patient, whichever is lower. The weight loss over placebo is still only around 7%. The cost in 2023 dollars is $387 for 5 pens. It's not, although it's TGA approved for obesity, there's no drug on the PBS for obesity management. So anyone who uses Saxenda will be having to pay around $400 a month to use this once daily injection. So the treatment gap. So before I get into some of the other medications that we use for obesity, I wanted to talk about the treatment gaps. So here I have a graph of weight loss starting at 0% all the way down to 35%. So the drugs that we've talked about up until now, plus intensive lifestyle measures, behavioral interventions, increased physical activity, all of these things will help you lose around up to 8% weight loss. None of them lose more than say 9% weight loss. So you're someone who's 100 kilos, for example, expect them to get down to 90 to 93 kilos using any one of these interventions. I mean, there's no reason why things can't be combined. There's no reason why, for example, someone can't be on Duromine and also on Contrave, for example. Additive medications can help people to get to target in the same way that we use multiple antihypertensives or anti-diabetic medications to get people to their target blood pressure or HbA1c. But on their own, each of these will only help you to lose about 8% weight at most. I'm not going to talk in detail about bariatric surgery tonight, but on average, after a gastric sleeve, people lose up to 40% of their weight initially and regain some of that. So at around the 2-year mark after a gastric sleeve, you'd expect a patient to weigh 20% less than their pre-surgery weight. And that would be about the average expected weight that people with bariatric surgery would maintain lifelong. Now, obviously, the more severe interventions like gastric bypass and things, that number will be a little bit higher. But there's this gap in the middle of 10 to 20%, which is that 10 to 20% number I mentioned earlier. And that's really that number which I've said moves everyone down one BMI class. And that would be really useful to achieve. But it's like either the interventions that we have for obesity up until now have resulted in too little weight loss or too much weight loss and, quite severe sort of things you have to go through as well. Especially with bariatric surgery, there is a risk of death that's around 0.5 to 1% on the table. So it's not the safest surgery in the world, and especially someone with a lot of comorbidities, which may be related to their obesity, it can be quite traumatic and dramatic surgery to go through. So it's not for everyone. So there's this treatment gap that we have of 10 to 20%. And the newer pharmacotherapies, which I'm about to talk about, will help to lose that kind of weight that we're looking at, 10 to 20%. So let's talk about semaglutide as Ozempic first. We all know Ozempic. Everyone in the public knows about Ozempic. Jimmy Kimmel, Joe Rogan, they're all talking about Ozempic too. So it's in the public eye a lot. Celebrities are using it. So we all know about Ozempic. It's a GLP-1 agonist. And everyone, although it's a drug that's approved by the TGA for use to treat type 2 diabetes, it's being used off-label by many for obesity. Now that raises some ethical sort of issues as well, where it's a drug for type 2 diabetes. There is a current shortage of Ozempic in the 1 milligram dose. And my understanding is even the 0.25 and 0.5 milligram doses are in short supply, depending on where you look now. And it presents an ethical sort of issue in that, if we're prescribing it off-label for people with obesity, and there are people people without comorbidities and obesity, and there are people with type 2 diabetes, which is uncontrolled, who you would argue have a greater need to lose the weight because they have comorbidities associated with their obesity, and we're depriving them of the supply of that medication, then it does present some sort of ethical sort of conundrums about, is it ethical to prescribe it off-label when even the people who need it to control their other chronic health conditions can't get it? So that's a bit difficult. My understanding is that supply may be spotty up until the end of this year, and there may be supply issues on and off with Ozempic.
Ray, I'm just sorry.
Yeah.
I'm just sorry, I'm from Raymond Kodsi.
Yeah.
So there is an update with that. Ozempic will now be very much in short supply until 2024 December, which means the TGA, if you go onto the TGA website today, you will see there is an update. So the recommendation is now not to start new patients on Ozempic for any reason, and just basically to maintain your current Ozempic patients. And then even with your new diabetic type 2 patients, only if there is no other option available to go to Ozempic. So it is going to be a longer term short supply. And also just, so it's both doses at the moment. So whatever that's coming into the country will be enough for what we have right now, unfortunately, due to this high demand, and it's global as well. And just the other update too, so it's actually semaglutide that's the challenge, not the device.
All right. Okay.
So it's the manufacturing of semaglutide that's the issue. So even in the US market, it's around the globe. So that's the latest update.
Mm-hmm. Thank you. So not to flog a dead horse, we know Ozempic is delivered once weekly by injection. We start at the 0.25 milligram dose, and that dose is doubled every 4 weeks, so 0.25 for 4 weeks, 0.5 for 4 weeks, then 1 milligram long term. The cost on the PBS is the same as other PBS medications if it is PBS indicated. If on private script, it costs around $140 a month at the maximum dose. The adverse effects, as with all the GLP-1 agonists, so I'm not going to repeat it every time, are nausea, vomiting, diarrhea, constipation, and pancreatitis is the other main one. Pancreatitis is rare, but it does happen, and patients should be counseled that if they have abdominal pain, that they should see their doctor or present to their emergency department to be tested for their lipase to make sure that they don't have pancreatitis. Also, it is contraindicated in patients who are at risk for medullary thyroid cancer. It's only rodent studies that have shown any association between semaglutide and medullary thyroid cancer. There's no human evidence at all to suggest that it has any association with medullary thyroid cancer. However, the precaution remains. So if patients have a family history or personal history of MTC, then this medication is not for them. So to kind of lead into semaglutide, the newer medications, so Wegovy is semaglutide at the higher dose. So at the moment we have Ozempic, which is semaglutide up to 1 milligram. Wegovy is currently sold in the US, and it's semaglutide up to 2.4 milligrams. And this has been the dose which has been studied in all the trials for the primary indication of weight loss, whereas Ozempic has been approved and studied for the primary indication of treating type 2 diabetes, as I mentioned earlier. Semaglutide, as Wegovy, the high-dose semaglutide, has been approved for use by the FDA in the US for treatment of obesity in people over 12 years old. So it can be used even in teenagers for obesity. It's not yet available in Australia. It is TGA approved in Australia, but again, in order to gear up the supply, I've been told that it will be available next year for purchase. At the moment, it's not available here in Australia, but I will talk about it. And this is the dosing regimen. So very similar to Ozempic, you start with 0.25, then 0.5, then 1 milligram. Then there's a 1.7 milligram step for 4 weeks. And then after that, you go on the 2.4 milligram dose once a week as well. It might be difficult to see from the back, but the pens look a little bit different as well, but would work very similarly in terms of dialing up the dose and administering the injection. So this is a summary slide of the STEP trials. So STEP is the acronym for the trial for semaglutide as Wegovy. So this is semaglutide specifically as indicated for the treatment of obesity in patients with and without type 2 diabetes. So there are many STEP trials. So up to STEP 10 is listed on here. I'm not going to be talking about 10-step trials in this talk tonight because we'll be here all night. And I will be only talking about them all very briefly. But I'll be talking very briefly, summarizing, sort of the first 5, like the outcomes of the first 5 trials. So there is a summary slide here of the outcomes of the first 4 step trials. So step 1 is all the way here on the left. The treatment period for each of these trials is 68 weeks, followed by an 8-week follow-up period. So each of these trials took place over 68 weeks. In the step 1 trial, which is the leftmost trial, here, people who are overweight, it examined people who are overweight with a BMI of 27 or above, or obese with at least one obesity-related comorbidity, except for type 2 diabetes. So this is studying the non-diabetic population. And these people were treated with semaglutide or placebo over 68 weeks. And the treatment difference between people on the semaglutide versus the people on placebo is about 12.5%. So people on semaglutide lost almost 15%. People on placebo lost about 2.5%. But the treatment difference was about 12.5% on treatment. 86.4% of people on the treatment medication, on semaglutide, were able to achieve 5% weight loss versus 31% in the placebo group. And 50.5%, so basically half of everyone in the treatment group, were able to lose 15% or more weight compared to 4.5% in the placebo group. So that's pretty significant. So if you could tell your patients that, you have being on this drug, you have a 50% chance of losing, 15% of your body weight. So going from 100 kilos down to 85, that's pretty significant, clinically and statistically. Step 2 is all the way here on the right. This is the similar sort of thing, except it looks specifically at patients with type 2 diabetes. We know that for whatever reason, people with type 2 diabetes struggle to lose weight, and they are less sensitive to GLP-1 agonists compared to the general population. So we can see that they still lost weight. So the treatment group lost 9.6% of their body weight compared to 3.4% in the placebo group. So the treatment difference wasn't as much as in the other trial, but still, a treatment difference of about 6% is still quite up there. And on the 1 milligram Ozempic dose, which is not shown here, 7% of people, there was a 7% reduction in body weight on the 1 milligram Ozempic dose. So still helps with even the people with diabetes. Step 3 looked at semaglutide versus placebo in addition to an intensive behavioral therapy program. So both groups in this trial, step 3 over here, had an initial 8-week low energy diet and higher target for physical activity. Then they were had a behavioral intervention every fortnight. They were attended a behavioral intervention to help them to lose weight. The average weight loss after 68 weeks was 16% compared to 5.7% on placebo. The co-primary endpoint, which was a 5% reduction in body weight, was met by 86% versus 47% in the placebo group. So again, significant results here. And step 4 was people who were overweight or obese without diabetes. But at 20 weeks, so everyone in this trial was on semaglutide for 20 weeks. At 20 weeks, people were then randomized to either go on placebo or continue on semaglutide. And so, as we can see, patients who continued semaglutide lost a total of 17.4% of their body weight, which is 7.9% of this was after the 20-week mark. But the people who went on placebo after 20 weeks regained 7 kilos, or 7% of their body weight. So they ended up losing a total body weight of 5% after the 68-week trial. So again, this kind of fits in with the idea that I postulated earlier that obesity treatment needs to be lifelong. If you discontinue a treatment for obesity, you will gain the weight back. Step 5 is kind of the long-term treatment. So now we've seen what happens if you discontinue. What happens if you do continue semaglutide for long-term? So this trial went out to 104 weeks. And so people who are on semaglutide for 2 years versus people who are on placebo for 2 years lost most of their weight at around the 50 to 60 week mark and maintained that weight loss of around 16% after that. So what this tells us for people that we put on semaglutide in the future is that if we start semaglutide, we would, after 1 year, reassess what the patient's weight is doing, because we'd expect that the patient would have lost all the weight that they were going to lose on semaglutide at that time. And then it would be at that point where you'd consider adding on other interventions or changing interventions if needed in order to further the weight loss that they've got if patients are not to target. The last drug I'm going to talk about today is tirzepatide, or Mounjaro. So Mounjaro is the even newer kid on the block. It's a multifunctional peptide which binds not only GLP-1, but it also binds glucose-dependent insulinotropic polypeptide, or GIP. And it's thought that a single molecule that binds both GIP and GLP-1 will will result in greater changes to glucose homeostasis. So it'll be even better for type 2 diabetes compared to the GLP-1 agonists alone, and weight control. So this drug works. So binding GIP enhances meal-stimulated insulin secretion similar to GLP-1, but it also stimulates glucagon secretion when you have hypoglycemia or euglycemia, but not hyperglycemia, as opposed to GLP-1s. Tirzepatide binds more to the GIP receptors than GLP-1, and it has a direct effect on lipid homeostasis. It may even have effects on or central actions on satiety, so it might actually work directly on the brain as well. The phase 2 trials showed that tirzepatide, or Mounjaro, decreases HbA1c in a dose-dependent manner in patients with type 2 diabetes. The drug has a half-life of 5 days, so like Ozempic and the other weekly GLP-1s, it's administered once a week as an injection. It's being assessed in 2 arms, in 2 different trials. So there's the SURPASS trials, which are looking for specifically tirzepatide in the treatment of type 2 diabetes and its effects on HbA1c. And the SURMOUNT studies, which is looking at tirzepatide as a primary treatment for obesity management in people with and without type 2 diabetes. So Mounjaro has come out on market as of last week, so you can prescribe it to your patients from today. It's TGA approved for use in adults for treatment of type 2 diabetes as monotherapy or in combination with other medication. It's sold in vials, so it doesn't come in pens like the other GLP-1 agonists. It comes in a vial, which the patient has to draw up into an insulin syringe and then administer as a subcut injection once a week. So patients will need education on how to draw up the drug and how to administer it to themselves safely. The medication starts at a dose of 2.5 milligrams once weekly, and the dose increases every month until you get to the maximum tolerated dose, or 15 milligrams. So it will take about 6 months to get to the maximum dose. The recommended retail price varies between $300 to $600 a month, depending on the dose. It's not on the PBS. They are applying for PBS approval for the indication of type 2 diabetes, is my understanding. But if a patient wants to go on this today, it will be a significant out-of-pocket cost. And it has similar side effects to the GLP-1 medication, so nausea, vomiting, flatulence, excessive belching. So patients need to be counseled on that as well. So I apologize for the poor resolution, but I've gotten these from the patient handouts for Mounjaro. So on the left is the vial for the Mounjaro, so that's what it looks like. That's how it's being sold in Australia. So, but each of the vials has a different coloured cap and a different coloured label. So, there's the 2.5 milligram a week dose that you take for 4 weeks, then you increase to 5 milligrams for 4 weeks, then 7.5, then 10, then 12.5, then 15. And you stay on each dose for 4 weeks. The recommended maintenance dose, so the doses that have been studied in the trials, are 5 milligrams, 10 milligrams, and 15 milligrams. So although the 7.5 and 12.5 milligram doses exists, they're intended as stepping stones. I suppose there's no reason why you couldn't use them, but that's not what's been sort of studied. So the outcomes are not as well defined. If we were to look at specifically the obesity trials for this medication, there's SURMOUNT-1. SURMOUNT-1 is a phase 3 double-blinded RCT. Again, kind of like the step 1 trial. It's people without diabetes but who have overweight or obesity with at least one comorbidity. And these patients were randomized to either the 5, 10, or 15 milligram dose of tirzepatide and treated for a total of 72 weeks. The co-primary endpoints were percentage change in weight loss from baseline, change in weight from baseline, and weight reduction of 5% or more. If we look at the results here, so in graph A, this is the placebo here, and the other doses are 5, 10, and 15 milligrams. As you can see, we're looking at percentage weight loss here on the right, so it might be small for people up the back yet again. I apologize for that. But on the 5 milligram dose, we're getting patients who are losing 15% of their body weight. At the maximum dose, we're getting people who are losing up to 20% of their body weight on the maximum dose of tirzepatide at the 72-week mark. We can see the trajectory of the weight loss on the graph B over here. So a lot of the weight loss happens within the first sort of 6 months on the treatment. You still lose weight after the 6-month mark, but the weight loss slows down up until sort of the 60-week mark, at which sort of point it kind of plateaus. If we look at the percentage of people who are achieving their weight loss targets, so this graph on the left, so both of these graphs are people who achieved certain body weight reduction milestones, so 5, 10, and 15%, and 20%, and 25%. One graph looks at patients who use the drug, completely adherent to the drug, continue the drug the whole way through the trial, whereas the other graph on the left looks at people who use the drug, but then, all the people who were on the drug or intended to be on the drug, but then for some reason either were non-adherent or discontinued the medication or needed other medications to rescue them. So if we look at even sort of the 20% body weight loss mark, so more than half of the people on the 10 to 15 milligram doses of this drug are able to achieve 20% weight loss. So that's, even the people who weren't on the maximum dose, more than half of them are going to be getting 20% weight loss, going from, say, 100 kilos down to, say, 80 kilos, which is massive. There was another trial, SURMOUNT-2, which again looked at tirzepatide specifically for weight loss in people with type 2 diabetes. Again, the numbers are smaller in terms of the weight loss outcomes, but they're still pretty significant. People with type 2 diabetes on the 15 milligram dose are losing 15% of their body weight. The graph on the right shows a similar trajectory in that most of the weight is lost within the first 6 months, and then the weight loss slows down after that. But we're getting significant numbers even in people with type 2 diabetes who historically have difficulty at getting their weight down. Again, even in people with type 2 diabetes, more than half the participants on the treatment dose, on the highest treatment dose, are able to lose 10 or 15% of their body weight. Well, at least 10%. About half on the highest dose will lose 15%. But still, this is pretty big news. So I'd like to end the talk there. I just wanted to summarize by saying that overweight and obesity is affecting 2 in 3 Australian adults at the moment. Southwest Sydney has the highest prevalence among the Sydney PHNs in terms of overweight and obesity. Obesity is a chronic disease. Obesity is not always, it's not really a choice. Genetically, people are programmed to keep at a certain set weight, and it's very difficult to get below that set weight without medication. And medication would need to be continued lifelong in order to maintain any weight loss. The perception that obesity medications are unsafe and don't work is being shattered by the development of these new medications, which are quite safe and quite tolerable for many. But the space is rapidly evolving. There are many more medications which are in development that I haven't really talked about today, including oral semaglutide, which is being studied and which has some promising outcomes as well. So the obesity space is rapidly evolving, and expect to see a lot of changes in the next 5 to 10 years. Thank you very much.